Begin recording. All right, guys. Okay, so hi everyone. Welcome to Noon Conference. So today's going to be diarrhea part 2 lecture. Last lecture was acute diarrhea. So we're going to be focusing today on chronic diarrhea. This has a vast array of differentials. So what we're going to do is we're going to kind of skim over the surface on how to approach a diagnosis. And then we're going to talk toward the end about some specific diagnoses that are very common causes of a chronic diarrhea and ones that are typically seen on exams. So a little summary about our last lecture. H&P, again, was the most important facet for trying to get to the diagnosis for both acute and chronic, as you'll see. Most cases of acute diarrhea are infectious. Most, again, don't require any further workup, and only symptomatic therapy is treated. However, inflammatory features may warrant certain workup, depending on the severity, patient's age, comorbidities, the duration, if it's more than 7 days going into persistent diarrhea, and then, of course, public health concerns. Most important therapy for acute diarrhea is generally volume repletion. We went over some of the World Health Organization's solutions that they recommended, primarily solutions with water, salt, and sugar. And then antibiotic therapy, empiric or targeted, may be indicated depending on, again, severity and the symptoms as well, but not always needed. So let's, again, just refresh our memories about the definition of diarrhea. So diarrhea is a symptom, again. It's a symptom of some greater condition that's going on. It's loosely defined as an increase in stool frequency, usually more than or equal to 3 times per day. Liquidity, which is usually types 5, 6, or 7 on the Bristol stool chart. And then volume, which is more than 200 grams per day, which is not really that great of an indicator because different things can affect this. Like, for example, high fiber intake can often increase the stool weight per day. Healthcare. So there's two things you got to keep in mind as well, just as a refresher, is what we define diarrhea as when we take history, and then what patients may come to you with what their definition of diarrhea is. And those are very important because that you need to distinguish whether they're actually truly having diarrhea or they're having other things. So again, healthcare providers generally say increase in stool frequency relative to the stool consistency. Yeah.
Sorry,
yes, of course.
They're not taping it, and I'm
Oh yeah, the taping is happening. I think the WebEx is not working, so they were not able to hear.
The WebEx.
Yeah.
The taping.
Mm-hmm.
All right, sorry.
Yeah, no problem. Would you like to try the WebEx to see if it's?
So they can hear you.
They can hear us, right, Rami?
And they have the slides.
Yeah, I do.
Can you see us?
No.
No.
Do they have the slides though? Ask them if they have it.
You forwarded them the. Oh, great. So just follow along with the PowerPoint, guys.
Okay.
Okay, great. So and then hyperdefecation also should be distinguished. That's usually in functional bowel disorders, and that's usually consistency that's close to normal, but they have multiple bowel movements per day. And then general public may come to you, your patient may come to you, talking more about the characteristics of the diarrhea and passage of the loose stool. And then, of course, it's important to distinguish between urgency and fecal incontinence. Dysentery is diarrhea with abdominal pain, mucus, and bloody stools. So just a kind of refresher from last lecture. So a couple of other things from last lecture is I'm going to go over is general physiology and general pathophysiology, just as a reminder. Small intestines and colon are responsible for uptake of about 99% of oral intakes of water. Usually there's 9 to 10 liters per day is taken up throughout the entire GI tract, and that includes your saliva and other secretions. Water that's transported in the GI tract is done so by osmotic forces, not active forces, and so that's important because transport of solutes often affects whether there is diarrhea or water retention in the colon or small bowel. And then normal absorption is usually greater than secretion within the GI tract, which helps concentrate the stool, and if it's reversed, that will often cause symptoms of diarrhea. And then general pathophysiology of the process. Again, pathophysiology really depends on what underlying process is going on, but this is kind of a general mechanism of which most processes are how they cause diarrhea and which sections are affected. The autocrine, luminal, paracrine, immune, neuronal, or endocrine pathways oftentimes are affected. And these all affect different things like the muscular system, blood flow, epithelium, and paracellular pathways, affecting things from permeability all the way to metabolism. So those are just things we talked about last lecture. So big picture again, diarrhea can be broken down into three general parts: acute, persistent, and chronic diarrhea. Today we'll be talking about chronic. Last time we talked about acute. Chronic diarrhea is typically defined as diarrhea that's been going on for 4 or more weeks. Now we'll be able to use some other other characteristics that people use to differentiate diarrhea, which is the large versus small volume, osmotic versus secretory, and then watery versus fat versus inflammatory. So we'll get into those in a little bit of detail. And one more time, just remember that certain things can mimic diarrhea, like pseudodiarrheas, for example, fecal incontinence and fecal impactions, which oftentimes severe impaction can cause irritation throughout the mucosa, which causes secretions, and these secretions can often spill out and cause the typically elderly patient to be incontinent, which presents as diarrhea, but really the underlying problem is not truly diarrhea. So acute versus chronic diarrhea. We talked last time that acute diarrhea was a bulk of most diarrhea cases that you do see, with infectious causes being primary causes of acute diarrhea. Over here, you see that chronic diarrhea is a very small part of the cases that you typically see for diarrhea, usually 5 to 10%. And so it presents a little bit more of a diagnostic challenge. One, because we don't often see it, and number two is because it might require a little bit more thinking, a little bit more workup to try to get to the answer. Resource-rich settings and resource-poor settings often have different causes of both acute and chronic diarrhea, but focusing on chronic right now. In poor settings, oftentimes it's still bacterial or infectious diseases that are cause of these diarrheas. And in resource-rich settings, which we're going to primarily focus our talk on, is oftentimes caused by functional malabsorptions or inflammatory bowel disorders that cause the chronic diarrhea. And then, of course, in immunocompromised patients, infections should still be top on your differential. So how are we approaching diarrhea that's chronic? So chronic diarrhea, more than 4 weeks, same thing. You start off with the history and physical exam. It's very important that you do take a very detailed history and physical. That's going to help you gauge a few things. One, it's going to help you move along this little algorithm, whether it's watery, inflammatory, or fatty. But also it's going to help you try to see what workup you want to order, rather than gunshotting all different types of workup, which can be expensive and confusing at the end. Oftentimes you want to try to narrow down what tests you want to order based off the really good history that you do take from the patient. Of course, watery diarrhea can be broken down more into osmotic, secretory, and functional, which we'll talk about. And then fatty can be distinguished between malabsorption and maldigestion. So just like last chart, history and physical is very important. So here I like this chart right here because it gives you differentials that are very likely based off certain history pearls that we see. So let's go down some of these lists. We have, onset. So last lectures, people mentioned that, onset's one thing that you talk about in history. So let's talk about abrupt onset diarrhea. What do you think someone comes in and said that they were completely fine, then all of a sudden they started experiencing diarrhea that wasn't progressive, and it's been going on for about 4 weeks' time? Typically, these are, again, infectious causes that might be relating to this abrupt onset. That's your thought. Maybe it could be an infection more so than other things. What about if someone had recently started a diet plan and they started drinking Diet Pepsi, or they're using artificial sweeteners in their, what is your thought about this kind of diarrhea? Right. So, artificial sweeteners, sorbitol, mannitol, these often can cause diarrhea over the long term because they're using these products not recognizing that this is why diarrhea is occurring. What about exposure to potential impure water sources? Maybe you went hiking and you have been having this diarrhea for about 4 weeks, 4 or 5 weeks now. Yeah, Giardia, chronic bacterial infections, cryptosporidiosis. And Brainerd diarrhea. I don't know if anybody knows what that is. That's in 1990s, early 1990s or early 1980s. There was a town in Missouri that had an outbreak of diarrhea in patients that would have it for, I think, close to 6 to 12 months. And they found out that this was typically from raw milk. People who drank unpasteurized milk, They still believe that it's a bacterial infection. They don't particularly know which bacterial infection it is, but it's usually from contaminated foods that cause this. And they've only had like one large outbreak in Texas, I think, since then, in 1996 or something. So, yeah. And then what about someone with chronic diarrhea and weight loss? Classic sign. They come and say, I'm losing quite a bit of weight. I've had diarrhea for almost 3 to 6 months. What are your top differentials in that? What is the one thing that you're thinking particularly? Could be. They haven't really told you it's non-bloody. They said maybe it's foul smelling. Malabsorption syndrome, right? So malabsorptions, pancreatic exocrine insufficiencies. Neoplasms can also be a thought as well. So these are kind of your thought process when you're going and taking the history. What about secondary gain from illness? Someone wants to miss work, and so they're coming in saying that they have diarrhea, and you start thinking that this might be the reason why social issues going on. What do you think, sir? Depression? Maybe. What could they be taking? Yes, suppurative laxative use or laxative abuse happens quite often, actually. And then what about someone coming in with excessive flatus? They're passing quite a lot of gas. Say that one more time. Can't hear you. Okay, could be, right? Carbohydrate malabsorptions, right? Oftentimes, especially people who have lactase deficiencies come in. That's one of their classic signs. I'm feeling bloated every time I eat certain dairy products. And then someone said this earlier, this classic, gross blood in the stools. I'm coming in with gross blood in the stools for 3 to 6 months, abdominal pain, cramping. What's your thought? Young patient, IBD, right? Very important. Malignancies, inflammatory bowel disease. These are all really important thoughts, you know. So cancers, especially in young patients, is becoming more and more common. Colon cancer. I was at Metropolitan for the last 2 months. We already diagnosed 4 people less than the age of 40 with, I think, in early 30s with colon cancer, stage 2, stage 1 colon cancer. So it's becoming more and more prevalent. So this is just kind of I'm not going to go over this, but this is just kind of show you. This is a very nice table or chart I found that shows all the differentials for each category of chronic diarrhea. There's a lot of them, you can see. But the good thing is that if you approach the diarrhea or approach the diagnosis in a systematic fashion, you can break it down to one of these large categories. And then even within this, you can start taking better history or certain tests, and that will try to point you toward the diagnosis, making the diagnosis quite simple over time. What we're going to do is we're going to go over a specific few diagnoses toward the end of this lecture, but our main goal is to try to find what kind of tests we're going to order and what kind of things we're going to look at, history we're going to take to try to get to these large, broad categories to help us at least pinpoint somewhat the diagnosis. So the initial diagnostic approach, let's go back to our algorithm. You always start off with your initial set of blood works, which are your basic CBC, CMP, albumin, ESR, LFTs, or iron, depending on what you might think, maybe celiac. And then your initial stool workup could also include stool white blood cells, fecal occult blood, C. diff, fecal calprotectin, and then stool O&P, depending on, again, your history that you got. These are all appropriate initial stool tests to order when you're still taking the history and when you're still trying to do the initial workup. And then GI consultation and endoscopic evaluation would be appropriate as well for a lot of these diagnoses. If you're feeling that early on in your differential, you're suspecting maybe it's inflammatory disorder that's been going on for some time, it would be appropriate at this point to refer and also get an endoscopic evaluation. So let's start off with fatty diarrhea, steatorrhea. History, like a couple of you have mentioned, you usually see greasy, malodorous stools that are floating in the toilet bowl. You have abdominal cramping, abdominal pains, and then often you see weight loss with malabsorption syndromes. Diagnostic tests that you can order specifically towards this history is quantitative stool fat, Sudan stain, and also near-infrared stool assay. This is a newer test that they're doing that's supposed to be a little bit more specific and a little bit more sensitive for stool, and they're supposed to quantify the stool for the weight of stool that was given better as well. Not everybody has it, but it's becoming more and more popular. Limitation to these tests include medication laxative use and also typical different diets. And the most common differentials, which we'll cover a couple of these in detail a little later, is carbohydrate malabsorption, celiac disease, gluten enteropathies, and then infectious causes, Giardia, Whipple's disease, tropical sprue. All of these cause different types of malabsorption and fatty diarrhea by history, right? So again, going down this differential will give you, going down this algorithm will give you these particular differentials. Then you can go through and see, are there any systemic signs? Are there any other findings that point you towards maybe, specific diagnosis? Did the patient have a surgery, a gastric bypass? All of these things could help you point towards that diagnosis as well. Inflammatory diarrheas, very similar to the presentation of acute diarrhea that are also inflammatory. You have bloody stools, fevers, weight loss. Systemic manifestations are very common as well. You have arthritis, uveitis, and erythema nodosum in certain autoimmune or inflammatory bowel disorders. And then the diagnostic tests you order are also often similar. People have chronic diarrhea that appear inflammatory. You want to order ESR, CRP, fecal leukocytes, calprotectin, and lactoferrin as well. These are some initial tests that you want to consider ordering, and that will help you gauge your differential. The most common ones, again, which I've marked with arrows, are ulcerative colitis and Crohn's disease, which we'll review a little bit more in detail. And certain invasive bacteria can cause this, or viruses can cause this as well. Clostridium difficile, everybody knows, can cause this. Enterohemorrhagic E. coli, Yersinia, and ulcerative viruses like CMV and herpes. Certain cancers can also be inflammatory, and specifically colon cancer. And then, of course, the treatment, very important to remember that people who are recently treated with certain therapies, especially radiation therapies, can cause certain inflammatory diarrheas as well. Bloody, which is radiation proctitis. And then watery diarrhea. So let's talk a little bit about watery diarrhea and how we're going to approach someone that came in with watery diarrhea. So out of these, the bulk are typically going to be watery diarrhea. And you want to start off with the stool osmotic gap or osmolar gap. And this will help differentiate between secretory and osmotic, which secretory will have a low gap, and the osmotic will have a high gap. And then, of course, you have a normal osmotic gap will point towards a functional diarrheas as well. So let's talk a little more in detail what the osmotic gap is. So osmotic gap is taking the normal osmolality of 290 minus 2 times the stool sodium plus the stool potassium. Okay. If a gap is more than 125, certain books say more than 100, chronic osmotic diarrhea is suspected. And if the gap is less than 50, chronic secretory diarrhea is usually suspected. And for these, you usually order stool electrolytes. We always see that order. That's why we typically order that, to calculate the osmotic gap. So what are certain differentials? What do we typically see? Characteristic findings that we see in secretory and osmotic versus functional diarrhea. So history is very variable. People can present with a lot of different things when it comes to watery diarrhea. It's a little harder to distinguish just based off clinical pearls that they tell you. Often, though, they're non-bloody. They're usually non-foul smelling, which differentiates them from inflammatory or malabsorption syndromes. But you do see in typically secretory diarrheas, they're large volume diarrhea. They often can happen at night, nocturnal stools. And even if you stop taking food, if you stop eating because of the diarrhea, you will still continue to have this diarrhea, which differentiates this from functional diarrhea. Osmotic gap is less than 50, and you typically see this in people who are alcoholics, bacterial enteropathies, enterotoxins. Early Crohn's ileitis can cause this. So Crohn's disease is known to be inflammatory, but in the early course, it usually causes a secretory large volume diarrhea that might not appear inflammatory. Typically, whenever there's ileocolitis involvement, that's whenever you see this. Hyperthyroidism, medications, microscopic colitis, which is can be between inflammatory and watery as well. A lot of these overlap. And then laxative abuse can cause secretory diarrhea as well. Osmotic gap, that's more than 125, causes osmotic diarrhea. So carbohydrate and malabsorption syndromes both can cause a malabsorption fatty diarrhea or a osmotic watery diarrhea. Osmotic laxative specifically. And then sugar, alcohols, mannitol, sugar replacement supplements can cause osmotic diarrheas. And then finally, the most common functional bowel disorder or functional diarrhea is irritable bowel syndrome. So hypermotility, smaller volume stools, and improvement at night and with fasting. So those are your typical differentials that we see here. So some more details for the board. So there are a few things that we're going to go over here that are more commonly asked on test questions. Because if we sat down and went over everything, it would take us forever if you went through all the differentials. But these are very common. So we're going to touch base a little bit more in detail about these four things: malabsorption syndromes, celiac disease, inflammatory bowel diseases, and microscopic colitis as well. So let's start off with the most common malabsorption syndrome. So what we're going to do is let's start off with this. A 45-year-old female has a 4-month history of diarrhea and weight loss. Labs show hypocalcemia, microcytic anemia, and an increase in PT. So what is the most likely diagnosis? What do you guys think the most likely diagnosis just with this vignette is? Well, I couldn't hear you say that. Malabsorption. Okay, good. So there is some sort of malabsorption going on. What do you think? What kind of malabsorption? What do you think is going on? Celiac. Okay, so yeah, so celiac's the diagnosis. What is the serology that you'll typically order? Correct. Very good, very good. And if positive, what do you do next? Don't all speak at once. I mean, huh? Biopsy, right. So then at that point, you want to start off, you want to go next to the endoscopic evaluation to confirm your diagnosis with a small bowel biopsy. So let's say you have a history of irritable bowel syndrome and iron deficiency anemia. You guys went over that pretty much. Celiac disease, right? Obtain IgA for anti-transglutaminase antibodies and endomysial antibodies as well. And after you obtain these, you can consider small bowel biopsy and upper endoscopy. And then you want to typically do a gluten-free diet once you do make the diagnosis. So what about chronic pancreatitis, hyperglycemia, history of pancreatic resection, or cystic fibrosis? What are your thoughts? What kind of diarrhea? Well, we know malabsorption, but what are your thoughts over here? What is the diagnosis, and what do you think you want to do? So malabsorption is the thought, right? So these are all malabsorptions. So what kind of malabsorption from what, though? Fat malabsorption. So yeah, what causes typically fat malabsorptions? And protein malabsorptions and pancreatic insufficiencies, right? So a lot of pancreatic insufficiency. You obtain excess fat, fecal fat in the stool. You can often get x-rays to see if there's calcifications in chronic pancreatitis. And then you treat with pancreatic enzymes. What about someone who came in with a history of previous surgery, small bowel diverticulosis, someone who has a dysmotility, and then combination of multiple vitamin deficiencies and elevated folic acid. Right, so bacterial overgrowth, very good. So you order empiric treatment with antibiotics. And what about someone who came in with a history of resection more than 200 centimeters of distal bowel, and the viable bowel that's left is less than 100, 150 centimeters? Short bowel syndrome, right? So this really, it's hard to manage the symptoms. So you just have to manage symptomatically and replete the nutrition. We had a patient that came, and these patients present with all types of nutritional deficiencies, selenium deficiencies, copper deficiencies, and it's very difficult to manage them. They oftentimes need expert nutritional counseling and advice, consultation to manage these patients. What about history of resection of less than 100 centimeters of distal ileum, coming in with voluminous diarrhea, weight loss, evidence of malnutrition? So the key word here is distal ileum. Say that one more time. Oops. Oh, all right, but so yes, so it's also short bowel syndrome, but with bile acid enteropathy. So they're not able to absorb their bile acids again, right? Especially in the distal ileum where they typically are, and so they often have these large voluminous diarrheas due to lack of bile acid being able to be uptake. And empiric trial of cholestyramine can be appropriate for these patients. What about a patient that came in, has malabsorption type of diarrhea that has also systemic symptoms of arthralgia, fevers, ocular or cardiac disease associated with this diarrhea? Someone said it? Yeah, right. Whipple's disease, right, very good. So Whipple's disease, right? So it's considered to be a infection, a small bowel primarily, and antibiotic therapy is indicated for long term, 12 months. Well, let's say a patient went to a tropical area, malabsorption syndrome, malabsorption type diarrhea, weight loss. Yeah, topical sprue, very easy, right? So the history again is very important. And what about someone who came in prolonged traveler's diarrhea? Someone with the travel, you gave them empiric antibiotics. They had what appeared to be typical as traveler's diarrhea, but it is now in the persistent stage. We're over 7 days, and now even going on to a few weeks. What are your thoughts? Giardia, exactly, right. So now you're thinking, okay, instead of being traveler's diarrhea, it could be Giardia, parasitic infections. So a little bit more about celiac disease. So this occurs secondary to, most people know it's wheat intolerance, right? It's the protein within the wheat or barley or rye that the patient is intolerant to, causing almost an inflammatory reaction in the small intestines that cause blunting of the villi. And because of the villi are blunted, it decreases surface area and causes malabsorption and diarrhea secondary to that. It's important to remember that celiac disease can often be mistaken as irritable bowel syndrome initially. And so if someone has IBS, but no other clinical features of IBS, and has been going on for some time, this should be on your mind to differentiate between the celiac disease and IBS as well. Findings that you typically see in celiac disease are chronic diarrhea with fatty stools. Bloating, weight loss, and abdominal pain are very common. You also have these systemic manifestations such as dermatitis herpetiformis, right? Papulovesicular rashes on the extensor surfaces. You might have isolated abnormalities in the LFTs without any other explanation, iron deficiency anemia, osteoporosis, and deficiencies in fat-soluble vitamins, right? A, D, E, and K. The diagnosis is typically done with IgA, anti-transglutaminase antibodies, or endomysial antibodies. But remember, if someone has IgA deficiency, you want to order the IgG at that point. You want to usually start off with the serology first and then proceed to the endoscopic evaluation and biopsy to confirm the diagnosis. It's important to remember that you don't want to start patient on empiric gluten-free diet because that might just confuse you further. It'll cause a false negative result on all your testing, and so then you really you'll be stuck with no diagnosis and only prolonging the symptoms as well. Treatment is with gluten-free diet once you have confirm the diagnosis. And oftentimes when a patient presents with failure of treatment, the two things that are most common whenever it comes to celiac disease, one is diet non-adherence. And the second thing is inadvertent exposure to gluten. They were not aware that typical food might have had these proteins in it, and so they still ate them. This is some pathology that we typically see when we go in. If it's early on in celiac disease, we don't see much changes endoscopically, but when we do take the small biopsies send us to pathology, we'll see these characteristic findings. So these nice villi that we see right over here, hair-like little fingers in the small bowel, are blunted, very blunted over here with a lot of inflammatory cells as well. And so there's a large decrease in surface area and a decrease in absorption of nutrients. So moving on, inflammatory bowel disease. So inflammatory bowel disorders are, also becoming a little bit more common, and they can also be debilitating as well. So it's very important to identify these early and treat them. It's also been found now that there's two different types of therapies with these inflammatory bowels: top down or bottom up, which means that you start off aggressive and then taper down, or you start off slowly and taper up, depending on the response. And it's now starting to be found that a lot of centers prefer to do early aggressive therapy to stop any complications, like, for example, fistula formations. So this is an idiopathic inflammation of the GI tract. There's two main types, which is the macroscopic inflammation caused by Crohn's disease and ulcerative colitis, which everybody's very familiar with, these two terms. So how do we differentiate these? There are certain clinical findings that differentiates these two inflammatory processes in the GI tract. So ulcerative colitis is typically mucosal edema, erythema, and loss of vascular patterns. Very common. When you go in and you do a colonoscopy, the first thing you'll see, or the first thing the attending will say is, oh, there's a loss of normal vascular pattern. It looks like just yellow mucosa. There's no vessels that are traversing through like normally. There's very friability in ulcers. The mucosa is very friable, and there's ulcerations throughout the rectum up and bleeding as well. In Crohn's disease, you usually see these linear type pathology, and there's these satellite lesions, or skipped lesions. You see them patchy throughout the GI tract, and they can be anywhere throughout the GI tract, from the mouth all the way to the anus. Any of these areas can be affected. The pathology, you usually see altered crypt architectures, or they say crypt abscesses or cryptitis on pathology. In Crohn's disease, you see granulomas, characteristic but often not found, and then you see transmural involvement of the entire layers of the GI tract, which is also a reason why you often see more fistula formation, adhesions with Crohn's disease than you do with ulcerative colitis. And then very commonly you see that smoking often alleviates the symptoms of ulcerative colitis. Not to say that you should encourage your patients to smoke, but smoking is a risk factor for Crohn's disease. All of these often have extra GI or systemic effects outside of the GI tract, aphthous ulcers, arthralgia, and back pain. So it's important to take a good history and pay attention to other possible findings that you may see that are related to the inflammatory diarrhea that the patient is having. So this is a nice little diagram that puts it into more visual aspect about differentiating Crohn's and ulcerative colitis. We went over a few of these already. So location is very important. So especially endoscopically, when we go in, we oftentimes try to get to the end of the colon and then intubate the terminal ileum to see if there is any involvement in the terminal ileum. Crohn's disease, you can see right over here, it's very patchy. There's skipped lesions, some areas of normal GI tract between pathology as well. And you can see it affect any part of the stomach. Endoscopically, you usually see this inflammation in the terminal ileum, and you see this edematous cobblestoning-like mucosa. It's very common or severe form of the disease is when they have perianal disease. Perianal disease is an indication to jump straight to TNF-alpha inhibitors to treat. With ulcerative colitis, you see it's typically limited to the colon, and it usually starts from the rectum and goes up. So when you see patients in the GI clinic, we'll distinguish it. Is it left side or the right side of the disease? If it's typically left side or specifically in the rectosigmoid area, it's not as bad of a disease and can be managed just with topicals. And you see ulcer formation within these areas of inflammation. You don't usually see skipped areas where the one area is skipped and the other area distal is more affected. And then you see mucosal inflammation in ulcerative colitis superficially, and then transmural inflammation in Crohn's disease. Complications in Crohn's can be severe. Some of them can be enterocutaneous or enteroenteric fistula formation, and then also enterovesicular formation, and stricture formations are very common as well. Treatment. So treatment's always a big thing with inflammatory bowel disease, and the thought right now is that you should start early and start aggressively. A lot of centers are treating with. So colonoscopy and biopsy to confirm the diagnosis are very important. So as if you see a patient out in the clinic and you're suspecting this, a pretty urgent referral to GI for endoscopic evaluation is needed. And treatment can be divided into two components. There's the active or remission component or induction component, and then there's the maintenance, where you want to maintain the therapy or remission, maintain the patient in remission over time. And then treatment can also be divided up in severity as well, severe, moderate, or mild disease. So mild disease, usually less than 4 bowel movements per day, mild elevation in ESR, and occasional blood in the stool. You want to start oftentimes with mesalamine, 5-ASA agents, sulfasalazine, and people who have disease isolated to their rectum can be managed just with the topicals or enemas as well, successfully. The goal is to put the patient into clinical remission. Oftentimes we see a lot of these patients histologically still have some inflammation, but the point is to try to have them symptom-free to prevent any further progression or complications. Moderate disease, you want to start off with some general prednisone, general steroids to put them into remission, and then start them off with 5-ASA agents to see if they will stay in remission. And then if they don't, or if they have severe disease, then you want to start off with IV steroids to put them into remission quicker, and then start off with some big medications like anti-TNF antibody, anti-TNF agents or other monoclonal antibodies as well. You want to remember that there are a couple of tests you want to do before starting some of these big medications. For anti-TNF agents. You want to screen people for other infections that can be that can oftentimes be exacerbated by these medications. And then thiopurine. You want to get the thiopurine methyltransferase levels before starting azathioprine or 6-mercaptopurine. These are very important drug levels or enzyme levels to get or infections to screen for before starting these medications. Treatment for Crohn's is similar in many ways. There are certain differences that are between this and ulcerative colitis. So you want to start off with, again, very mild disease. You can start off with 5 ASA agents, or you can start off with 6-mercaptopurine or ASA agents, which are usually better in Crohn's disease. And if they have any fistulating diseases or they have severe bloody diarrhea, then you want to jump to anti-TNF antibodies, which have been shown to be very effective in treating these and keeping people in remission as well. And then the last part is screening. Once you've diagnosed a patient, you've started treating the patient and they're in remission, how do you do the screening for these patients? So 8 years after the diagnosis, you want to start surveillance colonoscopies every 1 to 2 years for colorectal cancer for these patients. Okay. And then just very briefly, microscopic colitis. We don't see it very often, but whenever we do, it's very classic. They come in with this chronic, typically watery diarrhea with abdominal pain and weight loss. Endoscopically, the colon looks completely normal. It looks better than most healthy individuals, actually. But when you do the biopsies, you'll see these specific findings. 2 types of microscopic colitis we see as collagenous colitis and lymphocytic colitis. And it typically occurs in females, 45 to 60 years old, and it can be associated with certain medications like NSAIDs and PPI as well. Treatment is usually supportive. Occasionally, they do use budesonide topical therapy and stopping the inciting medications. So let's start off with some questions. I have 4 questions over here. I think I have a little bit of time, maybe a few minutes. Let's see how many we can get through. But I think these questions really put these points into perspective. So if you want to start off, Rohit, you want to start off with the first question?
23-year-old man is evaluated for chronic diarrhea. He has had intermittent loose stools over the past 2 to 3 years. However, over the past 6 months, diarrhea has become more severe, with 5 to 6 bowel movements per day constantly. Stools are described as mushy and malodorous and are accompanied by crampy abdominal pain and bloating. He has lost 5 pounds, 2.3 kilograms over the past 6 months despite consuming more calories. He has not had fever or GI bleeding and has no history of foreign. He has type 1 diabetes that is well controlled with insulin. He does not smoke cigarettes or drink alcohol. On physical exam, vitals are normal. He has evidence of muscle wasting and fetal edema. Abdomen is scaphoid with soft and increased bowel sounds. No distension or tenderness is noted. Lab studies reveal hemoglobin of 10.4 and PCV of 1.3. Which of the following is the most appropriate diagnostic test for colitis? So it seems like malabsorption.
Yeah, so exactly. So there's some kind of malabsorption going on, right? You see a young patient, fatty stools, malodorous stools. So what do you think you want to... So why not A, B, or D? Like, what are your thoughts?
It's too early to go for B and D. We don't really have a
Okay.
that's like too advanced. We don't have like the working diagnosis.
So you don't want to take biopsy first?
Yeah, it's chronic diarrhea.
All right, no problem. And what about A? Does that IBD? Right. Does that have any role in your differential or your diagnosis? Right. So no, you're right. So C, right? The goal here is that the thought is that there's a young patient with a malabsorption type of syndrome with weight loss. Celiac disease should be at top of your differential. You want to send the celiac antibody. And the reason you don't do EGD or small bowel biopsies first is because you want to get the serology, which is usually sensitive and specific. And if that's positive, you can do the invasive test after to confirm your diagnosis. And right, A is more so for inflammatory bowel disease, not celiac disease. What about number 2? So what do you think? What is the diagnosis here? Most likely diagnosis. Yeah, so young lady who had a gastric bypass surgery, now coming in with these symptoms of large volume diarrhea and has some vitamin deficiencies. Bacterial overgrowth is a thought as well. So what do you want to do? Okay, good. Yeah. So right, exactly. So treat with empiric antibiotics, as I went over during my presentation. Patient with bacterial overgrowth, commonly following bypass, should have these typical symptoms and should receive empiric antibiotics. Um, so the physiology that's going on is that oftentimes when they resect a large part of the bowel, the digestive enzymes that typically would pass through there, or an intestine motility that causes kind of regulation of the bacteria is gone, and so that usually limits the growth, and now there is none of those regulatory factors, and that causes increase in the growth of bacteria as well. And 3.
40-year-old man is buried for 6 months history of intermittent episodes of 2 to 4 loose stools per day. When he has diarrhea, he also notices crampy abdominal pain and bloating. He has not had nausea, vomiting, anorexia, fever, melena, hematochezia, recent travel, or any new medications, including antibiotics. He is overweight, but has been exercising and watching his diet for the past 6 months, and he has intentionally lost 6.8 kilograms. The main change in his diet has been switching to diet soda and using sugar-free sweeteners. He takes no medications. On physical exam, vital signs are normal, abdomen is obese, but soft with normal bowel sounds and no distension or tenderness. Which of the following is most appropriate management? A CT scan, B is colonoscopy biopsy, C, discontinue sugar-free sweeteners, D, gluten-free diet, C.
Right. So this was a very straightforward one, right? I gave it away to you in the vignette. So discontinue the sugar-free artificial sweeteners. And then final question. So there's a photo associated with this. This is the photo. So what do you guys think the diagnosis for this is? This one's a little bit more tricky. Let's go back to the vignette. So summarize the question. What kind of like particular pearls or important facts did they tell us? Right, so she had 6 to 10 bowel movements with nocturnal stools. Right, that's a little concerning. What did the colonoscopy find? Patchy distribution throughout the ascending, transverse, descending colon are shown. Oops, sorry. So what does that make you think? The terminal ileum and rectum show no inflammation, but there's patchy distribution throughout the ascending, transverse, and descending colon. Patchy inflammation. And it's transmural. Yeah, did they say that? Oh, did they? Right. Huh? It's transmural. Exacerbated by smoking. What else? Crohn's, yeah, good, very good. So yeah, Crohn's colitis, right? So a couple of things you want to remember is that it's a transmural, right? It's skipped lesions. You have anywhere throughout the GI tract, from the mouth all the way to the perianal area. It is a transmural, as someone had mentioned, yeah, smoking can often exacerbate this symptom more. And so this is what these typical things that you want to look for whenever you take the history, or endoscopically what we look for whenever we try to differentiate between these two inflammatory bowel disorders. Yeah, that's pretty much it. So this is a really good algorithm. Actually, this algorithm is from the American College of Family Physicians. I thought it was the most simplest one that was there, because ACG and UpToDate had some really complicated, huge algorithm. But this is a really nice one to follow. It just reminds you of what you want to do whenever you're trying to make the diagnosis of chronic diarrhea. So look at the history and physical, always. Then you want to, based off that, you'll be able to differentiate between fatty, water, and inflammatory and order your appropriate tests. They have a little box over here that talks about what history questions you want to ask, which we reviewed last lecture. And then you can differentiate between pancreatic insufficiency or other disorders, inflammatory bowel disorders or other inflammatory disorders, and then, of course, watery diarrhea, which will tell you you'll get the fecal osmotic gap, and you'll be able to see if it's high, low, or normal, which will tell you difference between osmotic, secretory, and functional, like we already discussed. Okay, so it's a good algorithm to kind of keep with you whenever you have a patient that presents to the clinic with diarrhea, to help you gauge this workup. Any questions? All right, that's pretty much it.